your evening with us tonight. Okay, I think we are going to just go ahead and start because our participants have started plateauing. So hello everybody again and welcome to Mini Med School. My name is Nate Nelson Maney.
And I'm Kevin Field.
And we are really happy to present tonight's topic, depression, anxiety, and psychiatry. It's a really important and underappreciated topic that we're very happy to share with you tonight. I would also like to introduce our students from the MD PhD program who are here to help facilitate tonight. We have Chelsea and YJ and Matthew here tonight, and they're going to be helping introduce the speakers and run the behind the scenes stuff tonight. And Chelsea actually organized this whole session tonight, so we're going to give her the honor of introducing our speakers. And without further ado, thanks for coming.
Hi, thank you again for coming. So I would like to introduce our student guest speaker today, Jeremy Fine. Jeremy Fine was born and raised in Chicago. He went to undergrad at WashU in St. Louis. He studied philosophy, neuroscience, and psychology with a minor in music and is an incredible musician. Currently, he is in his PhD first year, and he is in health policy with a focus on mental health. And then after the guest speaker, or after the student speaker, I'll introduce our faculty speaker, Dr. So. Jerry, I'll let you take it away. Awesome.
Thank you, Chelsea. I really appreciate it. That was really nice. I forgot how much embarrassment I feel while being introduced in places, so that's always good to remember. So we were hoping to start things off, just kind of figuring out what everybody else knows about this topic already and kind of fleshing out what things people have heard about depression and anxiety in the news lately, and how it is perceived on y'all's end. Wow, I just messed all of this up. I'm so sorry. I was hoping to open the Q&A.
Just go ahead and click slideshow again. Slides.
And then the Q&A. Awesome. And so I can ask a question. And
yeah, and then start with some on the back end.
Gotcha. Cool. So we were going to just start off with some preconceptions of what depression and anxiety were. Dr. Doctor is going to talk a little bit more about kind of some of the specifics and what it can look like clinically. And we just kind of wanted to hear what everyone's understanding is of depression. It's, as Dr. Doctor will talk about, it's something that could happen in 1 in 5 people, that something being a mental health condition. So it is highly improbable that nobody on this call has ever had depression. And it's even less probable that nobody has ever met someone with depression, if you yourself have not had it. So what do people on the call think of when they think of depression, or people in person? Either way. I could start singing if nobody types anything. Yeah. Yeah, that's fine. Sad. Oh, wait. I was like, yes, it said, yeah, sadness, rainy days. Why rainy days?
They embody sadness.
They embody sadness. Because rainy days, I mean, no motivation, wanting to sleep. Thank you. Yeah. So that's really interesting. So no motivation, definitely something we think of when we think of depression, just having a hard time getting things done. You know, that's, as Dr. will talk about, that's kind of part of the definition. Like having a hard time doing the things you want to do, even doing the things that you enjoy, can be really difficult. Exactly. Loss of interest in things that they used to enjoy. At least as a student, you know, from the people I've talked to that have struggled with depression, that can be one of the most frustrating parts. You know, when you're not able to enjoy the things that you feel like you should be loving, that can be a key for a lot of people, that something is going on. I know when I've been depressed in the past, that for me has been like, oh, I don't enjoy playing my guitar right now. That stinks. Can I speak to benzodiazepine withdrawal? Doctor can probably speak about that a lot. And that's a really great question. Especially, you know, one thing people think of with depression sometimes is substance use. We're going to talk about depression and anxiety, but these things don't exist in a vacuum. They exist with a lot of other things. Sometimes substance use, like benzodiazepines, that could be one way that somebody is trying to cope with their depression. You know, coping mechanisms can have there's a broad spectrum of how healthy versus unhealthy they can be. You know, someone could be trying to self-medicate to cope and get through the day, even though it's not necessarily what we would recommend. That is something that people go to when there's no obvious way through. How to move through it, to lift a bit or to improve the day or the moment. That's great. You know, when we talk about depression with patients, you know, depression is this really big nebulous term, but people experience it on a day-to-day basis. So similar in how, you know, throughout anyone's day, you have little victories. There's little victories in depression too. So, oh, noticing that this thing made me feel good today, or noticing that this little thing was helpful in me dealing with depression. You can kind of apply that knowledge to the future. So I think that was one I missed, maybe not. What have people heard about kind of how anxiety interplays with depression? Slash, if it has to, because we talk about anxiety and depression, like it's almost like hyphenated sometimes, almost like anxiety and depression. But you can be anxious without being depressed. Yeah, so stress is a big part of both anxiety and depression. Stress can, you know, increase your risk for having symptoms of anxiety or depression. And the really tricky part is anxiety and depression can stress you out. And when you're stressed about your anxiety and depression, that can make it a little bit harder to do the things that you need to do, which in turn can lead to more stress. And so it can become a really vicious cycle of trying to get through the day, being frustrated with yourself that you're having trouble getting through the day. And then you could kind of end up just in this spiral. And that's how these things sometimes can happen. You can have a stressor that you could say that precipitates, or that kind of brings on some depression and anxiety. So if you have like a major life stressor, let's say like a divorce or a death in the family, that's a really stressful event that can either in someone who has maybe been predisposed or had depression or anxiety before can kind of bring on an episode of that, or in someone that's never dealt with those things before. Major stressful life events are pretty intimately related with anxiety and depression. So long story short, yes, stress, anxiety, and depression kind of all go hand in hand. What do people think about how COVID may have impacted kind of anxiety and depression? There's been a lot in the news about anxiety and depression in a couple different populations, and like healthcare workers, in kids. What do people think about that? Slash, how did COVID impact? If someone had told me that they weren't anxious over the last 4 years, I'd be concerned, because anxiety is a natural part of life, but as we'll talk about, within limits.
There's a lot more isolation socially.
Yeah, and how might like isolation play with like depression or anxiety?
Cut off your support systems.
Yeah, exactly. So more alone time precipitating depression, absolutely. So, like we said with like the little wins, there are also the tools people have in their toolkits to cope. And during COVID, those went away for a lot of people. It was great that we had the ability to video chat, but especially elderly individuals, that became really challenging for a lot of people. And the isolation that was meant to help the most vulnerable in our population in some ways was contributing to more stress. Not saying it was that we shouldn't have had those, but it was one of the kind of unfortunate consequences of having that horrible illness going around that predominantly affected the elderly, is the elderly lost a lot of their supports. Same with, fortunately kids are really adaptable. I remember my 11-year-old cousin hanging out with her friends over Zoom in the middle of the pandemic and like seemingly having a very normal, enjoyable time with it. And I was very impressed at that. But still, kids had more time to be alone and away from everybody. So that contributed a lot. Even just like we were talking about stress, the first like 3 months of the pandemic were just chronically stressful. And just having that kind of constant, say like hypervigilance, or like always kind of waiting for the other shoe to drop, or always waiting for what's next. That is anxiety. And so at a certain point in the pandemic, all of us were kind of dealing with clinically significant anxiety, but the situation called for it. It made sense to be anxious because we didn't want to get sick and we didn't know what was going on. And so depression or anxiety, one way you can think about it is how most people felt like late March 2020, except all the time. And I don't know if you remember how you felt, but I was exhausted and scared, and it was difficult to get through the day without thinking about a lot of these things. And that's the reality for somebody who lives with chronic depression or anxiety. During a workshop, teaching returning from COVID online classes. Yeah. Dr. Doctor is going to talk a little bit about suicide and suicidal ideation. But unfortunately, these symptoms are on the rise for a lot of our youth right now. And it's scary, which makes it even more important to talk about, especially suicide. Not talking about it does the reverse of what we want it to do. And talking about suicide in no way increases someone's risk for suicide. In fact, it decreases it because you know you have someone there for you. So am I on time? Okay, cool. I think that was a really important way to wrap it up, or to kind of like dovetail at the end in suicide. One thing that we're gonna talk about towards the end of Dr. Doctor's presentation that I will briefly step back in for is like crisis resources and what to do if you or someone you know is experiencing a mental health crisis. It can be kind of overwhelming in terms of the number of resources that you actually have, but in the moment you might not know because it's really scary and it's really hard to help someone you love in that moment. I know that, I mean, even though I know about these things, I know if it's a loved one, I have a lot more trouble, thinking through and figuring out the exact pathway to go forward. So I'm going to put up some like phone numbers that literally having in your contacts in your phone can be super helpful. And these resources that we're going to talk about can be used for kids, they can be used for adults, and they can be used for anything. One thing that we talk about when we talk about a mental health crisis is we say like concern for hurting yourself or other people. And those are obviously some of the most urgent crises that we talk about in psychiatry, but that you don't have to be worried about hurting yourself or other people to be suffering. And a lot of these resources that we're going to bring up later are resources that you can use even if you're not at that point. Ideally, we would like to prevent people from getting to that point. And while it's not always possible, we can still try. So with that, I'm going to pass it along to, you're going to introduce, Chelsea is going to introduce Dr. Doctor. So thank you everyone for, well, we're going to take 5 first, which is great. We'll have a breather. So thank you for everyone online who participated. I'm really glad I didn't have to sing.
All right. Thank you, Jeremy, for introing our topic. We'll go ahead and take a 5-minute break and then return at approximately 5:55 for Dr. Doctor's talk. All right. I hope everyone had a nice break. We'll go ahead and continue now with Dr. Doctor's part of the talk. And I am honored to get to introduce her. And so Dr. Doctor completed her general psychiatry residency training at UNC and served as chief resident. After training, she stayed on as faculty with the Department of Psychiatry. She has a passion for teaching and mentorship throughout all levels of medical education. She supervises psychiatry residents and medical students in her role as an inpatient attending. Within the UNC School of Medicine, she serves as the CSP Psychiatry Clerkship Director for application phase students and is a clinical skills tutor within the Carolina Med Excel program. Her clinical interests are schizophrenia, or they include schizophrenia and bipolar disorder, as well as integrated and collaborative care models to expand access to psychiatric services. And I will go ahead and let her speak with us all. Thank you.
Okay, thank you so much, Chelsea, and welcome everyone. Good to see people in person, and then I can't see the Zoom people, but feel free to sort of ask questions along the way. I know our students are monitoring the chat, so we can just make it as free-flowing as possible. No need to be super formal. But Jeremy really set us up nicely for the topic big topic of depression, anxiety, and psychiatry. So thank you, Jeremy. Okay, maybe I'll just do this. I click it, wait.
Hmm. Okay, go ahead and try. Oh, is it on?
Mhm.
Yeah. Aha, this is the intro only. Hmm. Sorry about this.
Okay. All right, well, yeah, it wouldn't be a hybrid meeting without some sort of snafu. So, okay, great. So we'll talk about what is depression, what is anxiety, super briefly. Zoom out picture to talk about where the state of things are right now in the world and in North Carolina. And then a little bit more about UNC, Department of Psychiatry, resources to help you, things like that. Okay, I'll just click here. Okay, so zoomed out picture, we'll start with sort of some worldwide statistics, kind of bring it back into some national statistics, and then talk about where we are in North Carolina specifically. So some statistics from the World Health Organization: depression impacts 5% of the world adult population. So it's like 400 million people. So just to get a scope of the severity of the problem, but also to know that this is happening to individuals all around the globe, right? Not in any specific country or state or anything like that, but it is a leading cause of disability worldwide. So it's a really high priority that we address it and know how to treat it. Some national health statistics came out from the State of Mental Health in America. And there's a lot of really some shocking statistics here, but really wanting to emphasize how COVID has really disrupted some of and increased a lot of these statistics. But wanted to highlight a few: that 20% of the American population suffers from a mental illness in general, right? This is just mental illness, not necessarily depression, but that's 50 million people. Then, 4.5 thoughts of adults had serious thoughts of suicide, and these numbers have been increasing since 2011, which is, unfortunate. We want the trend to go in the opposite direction. And 24.7% of adults with a mental illness report an unmet need for treatment. So I'll discuss some of the struggles with mental illness and the lack of access to resources. I'll focus a little bit too on the problem with youth and adolescents when it comes to depression, anxiety, and mental illness in general. Again, the pandemic has really just exploded some of these statistics. So 10% of youth have severe major depression, 2.5 million. And this is higher in individuals that identify as more than one race. You can see how that 10.6 jumps to 14.5. Mental health concerns among high schools and college age students have more than tripled in the past year. Really, really enormous numbers. 15.7 of youth, this is age 12 to 17, experienced a major depressive disorder in the past year. Again, up about a little over 1%. Suicide became the second leading cause of death among children aged 10 to 14 during the pandemic. These are not statistics that we're happy to report. And really increased mental health related emergency room visits among adolescents. We feel this so intimately, I know, at UNC in the emergency department. Some other statistics, this just came in my inbox today, so I added it in there. This youth risk behavior survey that the CDC puts together, again, gives some other shocking statistics about youth and their mental illness and their unmet need. But basically, they survey high school students every 2 years about some different topics. One of them is mental health and mental health concerns. And these are some of the statistics. So 42% of students reported feeling persistently sad or hopeless in the past year. That's almost half. That's almost 1 in 2. 22% of students seriously considered attempting suicide in the past year, like really high number. And then 10% of students attempted suicide at least once in the past year. And these are increased in women, but then also the LGBTQ community has also been highlighted as another risk factor. And really the Surgeon General saw this data and really has called for action to address youth mental health crisis. So now we're boiling down a little bit more to our local level, what's happening in North Carolina. Really, we're not in good shape is where we are. They put out some data that shows the rankings of mental illness versus access to care throughout all 50 states in the country. And here's some of North Carolina's rankings. So for adult access to care, we rank 21, of course, out of 51 states. And then for youth mental illness and access to care, we're even lower, 42 of 51. So really, sort of in the middle for adults, but then really lower towards the bottom for youth. And then if you combine them all in terms of access to care, then we're 38 out of 51. Really lack of child and adolescent psychiatrists and limited pediatric mental health crisis centers is a big problem. So they suggest that like 50% of youth with depression are going untreated. So some of the things we'll talk about today, just, keep that in mind of like how significant this could be, and then these individuals not getting treatment, what that means down the road. So we'll talk a little clinically for a second. So depression is sort of the colloquial term, but in the clinical realm, we call it major depressive disorder. Now, not really relevant, but that's what the DSM-5, which is our guidebook for diagnosing, calls it. And like Jeremy said, there's really a multitude of contributing factors to depression. There's not one thing we can point to that says this is what causes depression. It's a combination of social factors, psychological factors, and biology. So all these things together is what could create, a perfect storm for someone to experience depression. But like Jeremy said, adverse life events, trauma, bereavement, unemployment, amongst many, many others. Genetic predispositions. There are studies that show that twins have an increased risk of depression, showing that there's some genetic contribution. But then there's this interplay between physical health conditions too, right? Hypertension, diabetes, obesity, having illnesses contributes to depression. And then it's a snowball cycle, right? Vicious cycle where then untreated depression can then worsen your physical illnesses if they're going untreated. Yeah, see you, Josh.
Sorry to hamper your movement, but kind of the audio is a little bit clearer when you're closer to the podium.
Okay, sure.
Thank you.
Yes, I will keep myself put. So it's all these factors together. Sometimes in med school, we learn about the two-hit hypothesis, where you have one impact from one realm, whether it's social, psychological, and then you have a biologic genetic predisposition, and then boom, depression. But if maybe you didn't have that biologic genetic predisposition and you encountered this life event, maybe you wouldn't get depression, right? So that's some theories about why some people have depression and some don't. Lots of comorbidities go along with depression, anxiety being a really big one. Like Jeremy said, sometimes they go hand in hand. We just say I'm back-to-back depression and anxiety. But it's a really big comorbidity, but then also addictions, drugs and alcohol, eating disorders, amongst many others. So some key features, we'll talk about, what are some symptoms that can qualify someone for a diagnosis, diagnosis of clinical depression. First is low mood, right? We ask our patients, what is your mood like? And maybe they say depressed, right? So that makes sense. Interestingly, in kids, their predominant mood change may not be sad and depressed, that we might think of it. They may get more irritable. So it can look a little different in kids. But certainly adults can get irritable too, but it may not be the predominant mood symptom that happens. Lack of interest. This came up in the chat, not enjoying things that you used to enjoy. The clinical term we use for that is called anhedonia, but really can be disruptive to life and really just impact that quality. So those top two symptoms, low mood and lack of interest, are two of the really quintessential features of depression. But then there's plenty others too, but you can see some of these other symptoms that happen in other illnesses or just other states of life, right? But they all can come together to create this clinical depression. So we have trouble sleeping, changes in appetite. Oftentimes it's, not eating a lot or not having an appetite, but it could be overeating and eating too much. So it's just any change in appetite. Trouble focusing or concentrating, excessive guilt or worry, trouble getting out of bed, hopelessness, and potentially suicidal thoughts. Again, not the case for everyone, but in its most severe form, people can feel suicidal. This little graphic just shows how it's a vicious cycle, right? Feeling sad, having low energy leads someone to naturally avoid the things that they want to do because they just don't have the energy or motivation to do them. And then that leads to social isolation, and we're back at square one, right? Our depression's now worsening because we haven't engaged in those things. And anxiety. So this is our pair, depression and anxiety. So technical, clinical term is generalized anxiety disorder. This is where we would have excessive worry for most days for 6 months. We could also experience symptoms like restlessness, easily fatigued. Again, you could see how this ties hand in hand with maybe trouble sleeping and low energy, trouble concentrating. We are seeing some overlap with symptoms of depression already. Irritability, muscle tension, troubles with sleep. This is, what we call generalized anxiety disorder, but then there's also panic attacks. I'm sure you guys may have heard of such a thing, but they may have other associated physical symptoms like fast breathing, chest tightness, sweatiness, these feelings of panic that can happen in sort of discrete moments and have specific triggers in specific situations. But as with depression, these symptoms really cause life challenges, which is why we call them a disorder, right? Because it really is impacting someone's quality of life and functioning. So how do we treat depression and anxiety? We'll go back to the concept of social factors, psychological factors, and biological factors. We have to hit every single one in a lot of cases, not all, but that's how we can conceptualize how we treat depression and anxiety. So what I like to say sort of as a psychiatrist is that therapy is a great first step in treatment, but some people need therapy and medications, and they really work best in combination if you're one of those individuals. But oftentimes therapy may be the first line treatment that your doctor may turn towards. In Psychology Today, I put this graphic up there. It's available to everyone, and a nice tool. You can just type in your zip code, your insurance if you have it, and then it pops out a list of different psychologists, therapists, social workers, and their different specialties. So that's how you can find them. But cognitive behavioral therapy is the specific mode of therapy that's most helpful and most often used to treat both depression and anxiety. So they have similar treatments too, which is, I think, a win for us. But cognitive behavioral therapy is known as CBT, and it really focuses on the interface between behaviors and emotions, right? They're so intertwined. Our emotions lead us to change our behaviors, and our behaviors then in turn impact our emotions. So it really encourages the person to challenge what we call negative automatic thoughts, those thoughts where our brain goes immediately to the negative when it's clouded with depression, right? We can't see the positive. It really hones in on challenging those. And then there's this concept called behavioral activation, which I'll talk a bit on the next slide or two, which I think is a really actionable thing that we all could use, but especially those struggling from depression, very useful. There's other modalities of therapy as well. Medications, we call those selective serotonin reuptake inhibitors, or SSRIs. This is our Zoloft, our Lexapro, our Prozac, things like that. That's usually first-line treatment from the medication side of things for both depression and anxiety. And, you know, unfortunately, they both take a while to work. So, you know, if you or someone you know is struggling from depression, you know, it's just really pervasive. It's not like we can prescribe a pill, prescribe a therapy, and then in the next week, they're going to feel better, right? These take, unfortunately, weeks to months to work and get to their effective sort of dose and state. I remember there was a question in the chat about benzodiazepines, and I'm happy to talk more about that too. Benzodiazepines can be used in the short term for anxiety, but unfortunately, the longer we're on them, our bodies do get physiologically dependent on benzodiazepines. And it seems that we're really only this is coming to light in the past few years about really the detrimental effects of long-term benzodiazepine use. So it really should just be used for a bridge until your SSRI, for example, could take effect, or you really get into CBT and you start learning the tools and building your toolkit. It really should be short term, but if someone is on it long term, it absolutely is possible to come off of them slowly. So I hope that answers that question. All right, so I promised to talk about behavioral activation because I think it's so important and so useful for, I think, all of us. But again, really a key strategic intervention for those suffering from depression. And so the idea is that your body wants to stay stagnant when you're depressed, but we have to force our bodies to do the exact opposite and get moving. That doesn't necessarily mean get to the gym and get out running, right? It just means move your body. There's this old adage that says depression leaves the body through the feet, right? Just any movement can help treat your depression. So we can harness this to our advantage. And it really, you know, the goal is to reduce the avoidance that we said, that vicious cycle of social isolation that comes with depression. It really sort of forces you to avoid that pit. So let's see. This little cycle over here I had up there that showed inactivity and depression were this vicious cycle, but then if you implement behavioral activation, then you do more of what matters to you, you feel better about yourself, and it all becomes a reinforcing cycle. So the more pleasurable activities that you force yourself to do, the less depressed you'll feel, is the goal, right? So what does it mean? Really anything that is meaningful to you. My suggestions is to start small, right? Like no change happens overnight where all of a sudden you make huge change. Sustainable change starts small. So start small and achievable. Think about, you know, maybe going for a short walk, or calling a friend, or for 5 minutes, or reading one book chapter, right? Like really small and tangible. So then the idea is that, okay, I was depressed. I went on a short walk, even if it was 15 minutes around the block, and now I feel better. So you add that data point to your head, in your brain, in your depression, and you say, hey, I actually felt really good after I did that. I should do it again. And so that motivation and energy really helps to be impacted by pleasure and mastery. So if you do things that are pleasurable or that give you that sense of mastery, those are the things to think of when you think of behavioral activation. And again, it's going to be different for everyone based on your interests and things that make you happy. Also connecting with others. We talked about social isolation with the pandemic. Oftentimes behavioral activation goes hand in hand with activating yourself to get talking with friends and family and like being with them. Depression can easily force us into a cycle where we stay in bed and aren't leaving the house and things. But even if you feel like, gosh, I can't even imagine like interacting with this person just because I'm so profoundly depressed, the goal is to sort of force yourself to do it, because then your brain will have those data points of like, that was actually quite pleasurable and fun, you know? So you keep adding those in your mind. It really hopes to break that cycle of inactivity and negative thoughts. Other things, I call this caring for your mental health because a lot of it can be very helpful in depression, but some of it can be helpful for, all of us just to stay well from a mental health perspective. And again, the goal is to practice these regularly so that they become good automatic habits and become routine without even having to think about them. So here's a couple bullet points. Prioritizing sleep schedule. We just saw how sleep is so relevant for both depression and anxiety. So prioritizing that, getting on a schedule, reducing blue light exposure, all the screens that we're on these days, at least an hour before bed, those should be put away to get sort of your maximum, most restful sleep. But then also being on a schedule, right? Not up till the wee hours of the morning one night and then back and forth, trying to get on a really good schedule. Fueling your body is another important caveat, right? But both nutrition, healthy foods are great, but I think sometimes we deprioritize hydration. Water can be so nutritious to the body. So feeding your body with things that it's going to thank you for. Relaxation exercises, examples include meditation, deep breathing, mindfulness, muscle relaxation. Again, you maybe have to look into which ones may make sense for you, but these can be really helpful. Breathing in particular really helps us, just pause. If we just take in a deep breath, it just forces that pause in life. And sometimes that helps us prevent us going into a negative cycle of depression or anxiety. Just pauses everything that's going on by taking a nice deep breath. And it really halts that fight or flight response that we feel when we're so anxious, right? Our heart's racing, we're sweaty, we're jittery and anxious. That's that fight or flight response. And the breath really helps calm down what we call our autonomic nervous system. And it gives you that time and space to then implement coping skills and go into another activity that's more pleasurable or more useful in that moment. Focusing on what's in your control. Gosh, this is perfect for anyone who struggles with anxiety. They're like, yeah, I wish I could, but my brain doesn't let me. But if you can, right, trying to bring yourself to the moment of what can I control of the situation and what is out of my control, because that can help you narrow down next steps, how to be actionable, and so forth. Goal setting, again, think about what your goals and priorities are in life, but starting small. Again, I put this up there twice about how important it is not to think, gosh, I'm going to go out and start running at 5 a.m. every single morning, because you're going to set yourself up for failure. So starting small so that each success is another sort of penny in your piggy bank of just successful outings and successful engagement activities. But same with goal setting, right? You'll set yourself up for failure if you set a goal that's too big for what you're capable of in that moment. Gratitude is another one. Just forcing yourself again to think of those positive things in life that you're grateful for. Being specific too. Don't just let your mind go to the nebulous, but being very specific about each day, what are 2 to 3 things that I'm grateful for? And write it down. I think that helps you when your brain is sort of spiraling into negative thoughts, to be able to look back at a tangible piece of paper that said, oh gosh, yesterday I was thankful for these 3 things. Apps are also great. No need to do pen and paper. There are apps too that can help remind you. You could set reminders on your phone, but really getting into the habit of practicing this on a regular schedule. It's been sort of shown that positive emotions decrease physical tension, which then in turn improves our mental health. So we're back to that balance and cycle of physical health impacting mental health and vice versa. Lastly, being kind to yourself and patient. Those are 2 things I would suggest reminding yourself of, whether you suffer from depression or not, but particularly if you do, because the world looks like a really scary and sad place otherwise. Okay, so that was some of the nuts and bolts about depression, anxiety, some take-home intangibles. But I also wanted to sort of showcase and explain what we're doing in the Department of Psychiatry. How are we tackling some of these big issues in mental health in general? So the 3 pillars of the department and many departments include patient-related care activities. So that's the clinical stuff, right? Seeing patients. education and training residents, medical students, what have you. And then research, whether it's bench work, clinical trials, those are the three pillars of what we do in psychiatry at UNC. So this is lots on the slide, but sort of broken up into two parts, top and bottom. We have our Center for Excellence for Eating Disorders, and then at the bottom, our Center for Women's Mood Disorders. So we talked about eating disorders being, commonly comorbid with depression and anxiety. Eating disorders being anorexia, bulimia, binge eating disorder, among others. UNC has a center where we have eating disorder specialists. We have an inpatient eating disorders unit as well as outpatient clinic. But they're right now doing a study about the genetics and environment related to eating disorders. So that's something new and exciting that's going on in that realm, but they've gotten really nationwide recognition for the Eating Disorders Center within UNC Department of Psychiatry. And then similarly, the Center for Women's Mood Disorders has gotten a lot of recognition and is doing a lot of really cool stuff. So we do have a perinatal inpatient psychiatry unit where moms with postpartum depression or maybe moms that are still currently pregnant are suffering from depression or postpartum psychosis. You may have seen that in the news at some point, but they can be hospitalized if there's an acute crisis. We also have outpatient women's mental health resources. But what's really cool is the chair of our department, Dr. Samantha Meltzer-Brody, led this study at UNC for the treatment of postpartum depression and led to be the first drug approved by the FDA to treat depression. It's called brexanolone or Zulresso. And it comes as a infusion for individuals with postpartum depression. So this has been really, really cool to be able to give to patients who are suffering from it and understand a little bit more about the mechanism of action of postpartum depression. I talked a lot about kids and sort of the state that we're at in terms of the child and adolescent mental health crisis or mental health tsunami, as sometimes it's referred to. The Foundation of Hope it's sort of cut off here a bit, but the CHAMP program, Child and Adolescent and Mood Disorders program, is getting started, where there's going to be, again, similar arms of research in terms of clinical education and clinical care. And Dr. Danielle Rubinov is chairing this, but again, highlighting some of the statistics that we're really hoping to reverse by this big foundation that we're starting within UNC. Healing young minds is the goal. More about kids in North Carolina and their access to mental health care. So thinking about the pillars, some of the priorities of the department include expanding access to child and adolescent psychiatric services, that's CAP, throughout all 100 counties in North Carolina. So that's trying to get more patients seen, educating the next generation of pediatric behavioral health clinicians. So that's that education pillar. Establishing clinical programs that can be deployed broadly, especially virtual care. That's been a big topic of how do we get access to the most people, even though we don't have enough psychiatrists to do it right now. The goal is eventually we will, but telehealth seems to be one solution to that. And then accelerating research, again, that pillar of research to partner and understand how to best serve child and adolescents who are suffering from behavioral health concerns. One more about kids. You may have seen in the news, but the old RJ Blackley will be converted into a mental health hospital for adolescents. There'll be about 56 beds for kids and adolescents. So we have a unit at UNC Chapel Hill, but not that many beds. And we oftentimes have to turn kids away and they sit in the emergency room because there's such few behavioral health beds across the state of North Carolina in general. But this will be one small piece of the puzzle in terms of addressing the mental health crisis of these kiddos. And DHHS Secretary Quinn Kinsley's been really pivotal and creating this change and advocating for the mental health services. So we're excited that this will be something new and exciting. This is in Butner, North Carolina. Other things to be hopeful for about the mental health state of the country. I don't want to end us in all doom and gloom. I know it's really tough right now where we're at, but I think there's a lot of positive things on the horizon. So this has been signed into by President Biden, the Consolidation Appropriations Act of 2023. I just highlighted a couple things up here that is in this. So more residency spots to train more psychiatrists. So a big problem is that we don't have enough psychiatrists as it stands now. So increasing residency spots. There's this such thing called a collaborative care model where primary care doctors serve as sort of the hub to treat behavioral health patients. And then they enlist psychiatrists and social workers as a team to sort of best help them. But that's really cool and exciting. More flexibilities about telehealth and reimbursement, mental health parity, again, for state insurances to pay at the same rate as other physical health conditions. Lots more money to support crisis services. Jeremy can talk a little bit more about that, but that includes like the 988, mobile crisis teams, versus law enforcement. Right now, if an individual has a crisis, a lot of times law enforcement are the ones to respond. And they're not necessarily equipped to handle behavioral health crises. And we know that they can really perpetuate a situation and escalate it unnecessarily, especially without that training. So the idea is to get more funding into these mobile crisis teams so that they can be the ones to respond to mental health crises. $7.5 billion for severe and persistent mental illness, as well as children with serious emotional disturbances. $47 billion for research via the National Institutes of Health, so more research. Almost $14 billion for veterans mental health care is a priority. And then Medicare to cover intensive outpatient services, which is basically one of the step downs from inpatient, is intensive outpatient, where an individual spends, much of their day going to therapy and engaging in groups. Another really exciting thing is the Suicide Prevention Institute, which has been able to be, developed based on this really generous gift of $25 million from a family who lost both their sons to suicide. And really, Dr. Patrick Sullivan will be the director of it. And again, thinking about clinical care, the education and training, and then the research aspects of how do we prevent suicide. I didn't talk about it a lot today in this talk about suicide, but there's a lot that we can still do to understand who's at risk for suicide and how to best help them and what resources to point them towards. So I think this is going to be really transformational in terms of just what we understand about depression and suicide, and then how do we get folks access to care. So, ending on, some warning signs about if you or someone is struggling from depression, and it does get to that point where suicidal thoughts are coming to mind, what are some warning signs either to look out for in yourself or a loved one? Irritability, agitation, significant mood swings, that can be a warning sign. Isolation, withdrawing from family and friends. We talked about how that's just a cycle, right? That's going to perpetuate itself. Feelings of emptiness, hopelessness, like there's no solutions, there's no way out. Helplessness, guilt, and shame are all emotions that can really be warning signs that someone may be contemplating suicide. Recklessness or impulsivity, increased use of alcohol and drugs, right? These are things that are going to decrease our ability to, think clearly in the moment and rationalize our next steps. But then if, individuals specifically express suicidal thoughts, maybe researching plans, giving away possessions, writing wills, these are all things to be concerned about if they're considering ways to die. And maybe Jeremy, what do you want to tell us about crisis resources?
Yeah.
Stellar. So as Dr. mentioned, there are a number of resources if you or someone you love is struggling with mental health, with a mental health condition. So 988 is the new phone number for the National Suicide Prevention Lifeline. So it's no longer this really long phone number that I could never remember that Logic put in a song. That was the only way people knew it. Now, if you just call 988, you will reach the National Suicide Hotline, and you will almost definitely in North Carolina talk to somebody within the state of North Carolina, and they can help direct you to services. I'm going to click on this link real quick because I think it has some really great information. So these are actually the crisis services in Chapel Hill that you could reach out to. And so there's a couple different options you have if you are in crisis or if someone you know is in crisis. So the Freedom House Recovery Center is kind of the main organization in Chapel Hill, or in Orange County, that focuses on crisis resources. So the first thing we should talk about is mobile crisis. So as Dr. alluded to, a mobile crisis unit is when someone in the community comes to you wherever you are at any time if you are in a mental health crisis. And from there, they can help either resolve the crisis, in other words, kind of de-escalate, help you figure out some coping strategies in order to avoid you having to go to the hospital, or if they can, or they can direct you to like other services if you are struggling so that you have next steps. And if necessary, they can help facilitate you going to the hospital. Mobile crisis is a phenomenal resource if you are just worried about somebody at all. There's a lot less stigma associated with somebody coming to you rather than you having to schlep all the way to the hospital and deal with all that. Someone can actually come to you if you are in a crisis. I have this phone number in my contacts. Like, you can literally just use this if you see someone on the street who's struggling that you are concerned about. Yeah.
There's a question from Donna asking if Freedom House Recovery Center.
I don't know, but there are mobile crisis units across the country. This just so happens to be the organization that runs the one in Orange County, North Carolina. Ideally, there are mobile crisis units everywhere around the country. We're working on it. Some of the other options that you have in ideally everywhere around the country, but not everywhere around the country, is these 23-hour observation chairs. So if you are having a crisis, you can go to this, it looks like a big living room with a bunch of chairs, and you can go sit down, talk to someone. They'll evaluate you, help kind of stabilize you, and at that like 23-hour maximum mark, they can either say, okay, like, we think you're safe, you're good to go home, like, can leave, or they can facilitate kind of a hospitalization. And then the last thing we'll talk about is police. So I think the police are in Chapel Hill, we have some of the best crisis intervention training nationally for our police force. That is not to say that the police are the best solution to a mental health crisis. However, in Chapel Hill, there's a little more reason to believe than elsewhere that the police force will be able to be equipped to handle somebody having a mental health crisis. So if you are worried about someone with a mental health crisis, let's say you see something happening in the street, and there's also a major safety concern, like you are worried that the situation could be dangerous, in that situation, what might be best is to call 911 and request a crisis intervention trained officer, because that officer could be the best equipped to both deal with the mental health situation and deal with the safety concern. Ideally, the vast majority of the time, you'd be able to call this phone number. So just put this in your contacts, because if you're in a situation in which you feel weird and don't know what's going on, this is like the phone number to call in the community, because it'll help resolve the situation. and they have in the least restrictive setting for the person who is struggling. That's my soapbox.
Sorry, Tim.
Oh,
Oh.
yeah, I'm sorry. I got you.
I think that was our last.
Okay.
Cool, thanks, Jeremy.
Mhm.
All right. Here's some more info about NAMI. So National Alliance on Mental Illness is a nationwide organization, but has specific county-specific groups and state-specific groups. I think, if you did have questions more about that, Jeremy would be very well equipped to answer those. But I think that is our last slide. So are there questions in the chat or things I can answer?
There was a second person that then did
Okay.
they full question. Is it possible to become positive after?
Yeah. So withdrawal from benzodiazepines, which we haven't talked about a lot in this talk, but can be uncomfortable. It can be life-threatening. So you definitely want to contact a doctor or potentially, be admitted to a unit for observation. But it is absolutely possible to come off even after multi-year use. Just needs to probably be slower than someone who's used it for, let's say, a few months. If it's multi-year, it just needs to be slower. But yeah, absolutely possible. Yes.
So there, I've heard of there
Hmm.
when does that
Yeah, so it's not a typical process that we use even today, I think, because it's a new development of understanding genetic metabolisms of different drugs. But I think when someone might turn to using those screeners would be maybe if they've failed multiple drug trials. And then you can sort of go back to the drawing book and say, oh, am I a poor metabolizer of it, or ultra rapid metabolizer of this medication. But I think mainstay would be, let's try a medication and see if it works, because it very well could. But unfortunately, a lot of those tests just aren't covered by insurance companies right now, and we don't exactly know how to interpret the data perfectly. So just a little bit cautious about it.
Related to that, you mentioned earlier that it can take weeks to months to figure out if one of these drugs is effective for you.
Mhm.
And that can be a long and trying process for people trying to figure that out. What would you say to a patient who's kind of struggling with that kind of idea of walking through this process of this might not work for a couple months, and then we're gonna try it out, and it might not work for a couple months until you find the right thing?
Yeah, it's a hard conversation because it is the reality. I think the solution would be to really emphasize the engagement in therapy, psychotherapy, coping skills, whether you can deliver that to the patient or refer them to a therapist. Because I think that, although that will take time too, it can still be more effective in the moment than those antidepressants, which take a long time to work.
We have a question from Eric Lai.
Mhm.
Are there resources for family and friends who are supporting someone who's suffering from depression? More on how to better support the patient.
Oh, yeah. I wonder if NAMI might be a good resource for that. So if you could Google NAMI, it has patient-friendly information about depression, but then also, how to understand it for someone that you love who's might be struggling.
So there are a lot of online psychiatry companies that have been popping up recently.
Yeah.
Are those good? Are they as good as in person?
That's a hard one to answer because I don't know. I can't say that they're not good. But I do have reservations, I think in general, about turning to those big companies just because they're so new and we don't know a lot about them yet. I'm also just tend to be more of like a traditionalist of like in person and like social connection, like feels like it has to be better than the virtual stranger, but I don't have data to support that. It's just a sort of gut feeling. But I think, you know, we can't knock it because it probably is the way of the future, and we need to figure out how to implement best practices for the ones that do pop up. Same thing with the sort of therapy ones. I think there's ones coming up that are like 24/7 access to therapy, and maybe I think even UNC undergrad is utilized. A lot of campuses are utilizing them to have students be able to access these therapists during crisis hours. I just don't know enough about it to comment, but I'll be very curious to see if they're beneficial because it could be a great solution. But we'll have to see. Yeah.
So I know that therapy and fixing the psychiatrist is a good thing for everybody to do.
Yeah.
But how do you talk about like engaging with psychiatrists and treating mental health disorders with people who might be biased against psychiatrists or be afraid to go into a mental health setting and view it as a
Yeah, gosh, great question. I think normalizing it as much as possible, right? Of like depression being a mental health condition, but these are all in turn physical health conditions too, right? So I think the main answer would be to normalize it, and then to just encourage the individual to just try it once, right? Just try anything once and see how it is, because my hope is that it's not as scary as someone might be envisioning, but also with the caveat that, you know, for therapy especially, I think it's important for psychiatry, but for the one-on-one psychotherapy piece, it really does rely on a connection. And so if you're really not connecting with that person, that's okay, right? Maybe try a different one after that. But that can still be a barrier, right? Because if the person was already sort of apprehensive about engaging and then they go to the appointment with a therapist and they're just not feeling it, it's hard to then say, well, there might be another one out there. But I think at the get-go, really framing it as, you know, this first one, it's like dating, right? It may not be your forever therapist at first, but like either, you know, if there's a spark, just give them a little more time, or try again. And there might be another one who fits their needs a little bit better. That's another reason why I think Psychology Today is so helpful, because it breaks it down by, you know, gender, religiosity, family troubles, like all different like nuances. And so that can help narrow it down to who might be a good fit.
We have a couple of questions online.
Yeah.
The first one is, does drug and alcohol use increase your chances of mental health disorders?
Yes, it's the classic chicken or the egg question, right? So I think a generally well accepted hypothesis, and one that I carry around too, is that individuals who turn to drugs and alcohol, they turn to cope with something, right? Like they're trying to alleviate pain somewhere. And so where that pain is originating from, oftentimes is a mental illness. So the answer I think is yes. And it goes back and forth, right? Between exacerbating mental illnesses, right? So we talked about depression and anxiety. If someone also is using alcohol or drugs to cope with that, it actually is just going to worsen the symptoms. And we know that quite well, that, you know, depression or alcohol and drugs can sort of make you feel better in that moment, but over the long term, it really is going to worsen those symptoms. But it really is the chicken and the egg. But chronic long-term use of drugs and alcohol absolutely can sort of make you forget why life is worth living and those coping skills.
The second question, Lilia asks, how does traditional therapy approach non-traditional holistic alternative approaches such as hypnosis, meditation, plant medicine, others for issues with anxiety?
I don't know a lot about the complementary medicine approaches. I mostly just know the traditional psychotherapy and medications piece. But some people, you know, report benefit from different sort of supplements and vitamins and meditation, things like that. I think just always talking with your doctor if you start supplements, because they can interact with other medications. So I'm not informed enough to be able to comment on the efficacy, but that I've heard people can benefit from them.
Stacy Field asks, do you have any experience with and opinions on psychedelic mushrooms for the treatment of depression or mental illness?
Yeah, shoot, I should have put that on my slide, because UNC is doing really cool research about psychedelics, specifically like psilocybin. You know, maybe, I don't know if we're asking about sort of microdosing or the studies, but it's looking promising, but that is not an endorsement to pursue that as a treatment. But the studies are really exciting, especially for people with trauma disorders, but also depression in sort of a controlled setting, of course. But it's looking promising. You know, that sort of leads me to also mention some other maybe less traditional treatments for depression, but they are out there. So we talked about the traditional CBT, SSRIs is sort of our go-to as first line, but electroconvulsive therapy, ECT, is another one maybe folks have heard of. I think there's a lot of stigma around it still in the community, but it is sort of a induced seizure that can help treat symptoms of depression fast. So, you know, if we're someone who's struggling really like a lot in the moment, maybe they've tried many medications in the past and therapy and they're feeling acutely suicidal, ECT may be, you know, an option for them to get feeling better faster. It really is the most effective depression treatment we have, but I think because of stigma, because of, you know, barriers related to insurance, logistical barriers about ECT, right? Going in for a procedure maybe 3 times a week leads it to be more difficult to access, but really good option for a lot of people struggling is ECT. Ketamine is another one that's been shown to improve, again, acute suicidality. UNC was also a site to do a study about intranasal ketamine, and it's, again, really promising.
Awesome. We have one last question from Mike Chapman.
Mm-hmm.
Is not feeling anything a mental health disorder. How do you cope with that?
In and of itself, no. But I think I would ask myself, are there other symptoms going on in relation to it, right? About sleep, appetite, energy, motivation, feeling, you know, enjoying pleasurable activities or not. But I do suspect that if you're not feeling anything, it's because you also aren't feeling pleasure from pleasurable activities that give you a sense of joy and mastery. So I think the coping skills would be similar though to depression, right? I sort of pitch these as we can all benefit from them, but I think people with struggling from depression can too. So that behavioral activation, really getting out there and seeing what those pleasurable activities do for you, and then kind of going from there.
All questions from
Okay.
So I'd like to give a big round of applause to Dr. Doctor. Thank you very much.
Thank you for having me.
Hey, just wanted to say in closing, thank you to everybody for attending virtually and in person. Thanks again to Dr. and Jeremy, our speakers. We'd also like to thank Chelsea, YJ, and Matthew, our students who helped run today. With that, we hope to see you all next week, be that in person or online, for a session about arthritis and rheumatology.
And Nate will be the speaker for that session. So you've got a great talk to look forward to.
It's going to be fun. Please come.
Have a great night, everyone. Thank you again for coming, and we hope you enjoy the rest of your Valentine's Day.